after which we would have a closing remark, and most importantly, we would also have a B2B sessions for companies that are interested in speaking with these companies or whichever company they have interest in. The companies are ready and willing to listen to you and speak to you, and we will give further instructions as we go. Thank you again, and I'll pass it on to Ms. Ayelet Levenkamp to give her opening remarks.
Good morning everybody, and thank you for joining us this morning. And of course, thank you to the Israeli companies for joining us too. My name is Ayelet Levenkamp, like Edwin mentioned, and I head the Trade and Economic Mission here in Ghana. In the Trade and Economic Mission, we work to enhance economic relationships between Israel and our country of destination, Ghana and South Africa in this case. And we always look for areas we feel there's a mutual benefits and really opportunities for growth and improve the livelihood for both countries. And I opened the trade mission here in 2018. There were some sectors that were kind of obvious. Israel is very well known for, at least in Ghana, like agriculture, water, security, and so on. I think health is one of the less known but super promising sectors that from the beginning it was clear for me that we have to be focusing on. And this, of course, got even more of a push now with the coronavirus spread and the focus on the health systems, strong backbone for the resilience of any country. It's less known, so I will elaborate a little bit about Israel. It has a very strong healthcare system that is very supported by the private sector companies, both in the pharma, very strong pharma industry, and the medical device. And recently also a lot of digital health companies that are coming up with very interesting innovations for remote care. And ways to why am I echoing? I don't know, but ways to give care in a way that in ways that were not done before. I think that one of the manifestations of the strengths of the Israeli ecosystem was in very efficient vaccination process that we had, where we were able to vaccinate the whole country in a very short time, mostly due to the strengths of the health system and the way it is managed digitally, when with a lot of information collected, which was very appealing to Pfizer at that point, and that's why the cooperation was formed. I believe that, especially like Edwin mentioned, in the area of wound management, we found in the last years a lot of interest, both from Israeli companies that have interesting and relevant solutions for the market, and both in the Ghanaian market as a real need that comes from the field, from the hospitals, from the nurses and the doctors. So we are very, very happy on the opportunity to present some of these solutions. I hope that they will find interesting. These companies are looking to come into Ghana. Some are already here. Some are mostly looking for new partners and partnerships to see how they can come and share the know-how and knowledge here in Ghana and in South Africa. So we really hope that this event will be just the beginning of new partnerships and growth of these solutions here into Ghana, because really wound management is all about healing and improving lives, and that's what we want to do here. So thank you very much for joining. I hope you will find it interesting, and I encourage you, if you find one of the solutions relevant and interesting, to not hesitate and meet the companies, talk to them, only conversation and the interactions can bring these things forward, and there's always a room for that, and we of course are here to support it. Lastly, I just want to thank Edwin, Mr. Edwin Aqua, head of the health sector, for the initiation and organization of this session. Thank you very much, and I hope you enjoy.
Thank you very much, Ms. Ayelet Devinkap. We appreciate it. I can see we have a good representation here, 42 and counting. So we hope that we will get more people joining. So we jump straight in, not wasting any more time. And Mr. Moshe, he gave his profile here. Moshe Lichtenstein is the head of international business development at Red Dress Medical. And he's added his telephone number and email address. If you care and you're interested in engaging him further, please do. As he's presenting, I would put up a Google form if you're interested in meeting Moshe immediately after. Stay on, and then we will organize a one-to-one session for you. So Moshe, the floor is yours. Thank you.
Thank you very much, Edwin, and just good morning to you, and thank you to you and Ayelet for arranging this webinar this morning. I'm going to share my screen. Let me know once you see it. Just give me 1 second. I just need an indication if you can see.
Yes, we can see it.
You can see the screen? Okay, great. So good morning, everyone. My name is Moshe Lichtenstein. I'm actually South African, so I live in Johannesburg, South Africa. I'm a medical device executive. I've been working with medical devices in the Israeli medtech sector for the last 10 years. And most recently, in the last year, I've been distributing Actigraft in South Africa. And we've had some remarkable achievements from South Africa, which I'll talk about later on in this presentation. And my hope is really to bring Actigraph to the rest of Africa through South Africa as the conduit, as a proud South African. But most recently, I've taken up a role in the company as head of international business development, and it's really my goal to integrate this novel and extremely effective device into the public and private healthcare sectors around the world. And to really just integrate this amazing technology and make it available for all the people that need it, the vast amounts of people that need it, and those that suffer from chronic wounds around the world. So today I want to speak about our product. I'm going to take you through some highlights, some of the case presentations. I've left my contact details there. Please be in touch if there's anything that I can assist with going forward. So what we're talking about today is Actigraft, and really how we define it is that Actigraft is the most innovative and effective biologic wound care treatment on the market. This is what it looks like. So just keep this in mind, and we're going to go through exactly how it works in the next few slides. So Actigraft is based on Red Dress's proprietary patented technology, and it's FDA approved, it's CE marked, and in every country, we're in approximately 35 countries and counting at the moment. And in all these countries, we've achieved our local regulatory approval in all those countries. And really what we're doing is in real time, we are producing an in vitro clot from a patient's whole blood. Once we apply it, the clot's tissue serves as a protective covering and a biologic scaffold, and the most ideal wound microenvironment to promote the natural wound healing process of the body. Let's take a step back and understand, when we speak about a chronic wound, we have a patient that has a diabetic foot ulcer, pressure ulcer, venous ulcer, potentially a skin trauma or something that hasn't healed in a long period of time. What happens is that there's a decrease of blood or vascularization going into that area, and that causes this wound to stay. And we understand that some treatments are able to heal them, and some treatments eventually over time are ineffective, and eventually that person can lead sometimes to an amputation. What people have thought traditionally is that the blood is an amazing, the natural physiology of our human body. If you and I go into our kitchen now and perhaps we're cutting an apple, we might cut ourselves. There's a whole signaling process and a natural physiological process that happens in order for our body to heal the wounds that we get. In these people where they have these chronic wounds, that signaling has been switched off. So these wounds are completely dormant from the natural physiological response that the body normally produces. What we want to do is we take the blood and we protect the whole integrity of that blood clots, and we put it onto the wound. Now, you might be thinking straight away that you've heard of platelet therapy, where we take, the thinking is, let's take platelets, the concentration of platelets, we put them onto the wound because platelets deal with the healing properties of the blood. So therefore, if we put a concentrated amount on that wound, that will stimulate the healing. But we see that that's not the case because it's not such an effective mechanism. We also see some people have thought, well, if we bring hemoglobin, which is the binding agent for oxygen, we'll bring in a whole lot of oxygenated blood supply into that area, and that perhaps might be the trick to heal these wounds. But we see that that's also ineffective. What we're doing is we're saying, let's take the full whole blood complement, let's preserve the integrity of that blood complement, and let's put it onto that wound and stimulate the healing and trigger the natural inflammatory and the natural healing cascade that takes place. I'm going to take you through this video very briefly. I'm going to narrate you through it. And really what we'll see here is just a mechanism of action of the product. We'll see here, we've got a patient that has a diabetic foot ulcer. In this instance, we've produced this blood clot, which I'm going to show you how we do it shortly. But what we see here is really, if we zoomed in a microscope and looked at what we see in a blood clot, it's similar to what we'd see in a scab. We see that there's a fibrin mesh, the layer of intertwined fibrin, which really creates a scaffolding for that wound to heal and ultimately contract and close. And interlaced between this fibrin layer, we see that there are these red blood cells. And we have to understand that we're not just dealing with the red blood cells themselves, but everything good about the natural physiological healing process that comes with these red blood cells. So for example, so we'll see here in this video, I'm going to zoom forward a little bit in the interest of time, but we see that there's this fibrin scaffold that starts binding, really creating this microenvironment and infrastructure to heal that wound. Again, we're looking in here. But more than that, we see also the hormonal responses, the necessary hormonal responses in order to activate the healing process in that wound site. So we see the vascular cell response, we'll see erythrocytes, so the red blood cells, we'll see macrophages coming in to clean out that wound. And really this is triggering growth factors, which is important. And this really just signals what would normally happen in the human body, which is switched off in these particular patients. So Actigraft, this is what the patch looks like once it's made. And again, I'll show you a little bit later on how it's made. The indications are that it's for any chronic wound. So diabetic foot ulcers, pressure ulcers, venous ulcers, skin tears, trauma wounds, anything within the chronic wound space. So we say that it initiates and moderates the healing process, and it promotes vascular growth. All the things that I'm saying today have been validated by clinical studies, and I'll point you to our website to go and look at those. We release growth factors, which is essential to this healing process, attract macrophages to clean that area, as I mentioned previously. It acts as a scaffold and it fights infection. So you're probably asking yourself, why should we use Actigraft and why is this relevant? And I think my experience, especially in the South African context and understanding Africa, I'm going to speak specifically to these points. Firstly, it's cost effective. If we look at what it costs, particularly from the perspective of the clinical studies have shown that Actigraft heals 72% of patients that we treat, which is a significantly high number, and it really depicts the high efficacy of this device. So when we heal a wound, in those 72% of patients that are able to be healed, we have taken wounds, and depending on the size, we're healing these wounds between 2 months and 3 months. It's a weekly application, so I'll take you through the procedure again, but it's a weekly application. And what we are saying, depending on the size of the wound, we are able to heal these wounds in a shorter amount of time in those that it is effective in. It's efficient. So obviously we're providing this natural healing environment for the body to work as it should. And we see that this proceeds unhindered. It's simple to use, again, with the context of the African discussion and maybe emerging markets that may be on this call today. The simplicity is something, just unbelievable to see. We conducted an observational pilot in South Africa, and we used both public and private settings. And in the private setting, in the public setting rather in South Africa, I saw that in Tembisa Hospital, which is a renowned hospital that has a wound care center of excellence, Dr. George Belando is a widely accepted key opinion leader in wound care. He was treating 8 patients consecutively in all the different rooms. He was doing the advanced wound care. The nurse would come in, produce the clots, put it on the patient, and we had some unbelievable results. So it's super simple to use during lockdown. I was able to train multiple clinicians just by sending them the kits and showing them the short video demonstration. So it's autologous. So we're using the patient's own blood to heal themselves, which makes it they're very limited AEs, adverse events when it comes to using this treatment. So it's very safe. And again, we're providing this effective wound management system from the patient's own blood. And often what we see is that these patients actually feel more integrated within the healing process because they are part of that process, because they are using their own blood. We're seeing that there's an ease of pain. We're currently conducting a randomized control trial in the US and actually hopefully 2 sites in South Africa soon. And we're trying to document this widely recorded ease of pain in the localized area. We have 9 peer-reviewed and published clinical studies, and this is continuously growing and evolving. As I said, we're doing a randomized control trial. All these are available on our website. I want to take you through the product demonstration. I might skip some of the parts. Just bear with me. I'm almost done with this. So just taking you through it, exactly how it works. So what you're seeing over here is the kit. The patient, as I said, would have this treatment done. Everything that is needed per treatment per week is done, is provided within this kit. In the kit is spaced between 2. So we see that there's the blood drawing compartment, and then there's the compartment of all the other things. Over here, we draw the 2 vials of blood. So we take 20 mils of blood from the patient. We fill those vials up. And what we see here is the coagulation mold. So once we draw this blood up, we are then going to mix the blood with a small vial of calcium gluconate, which helps congeal and coagulate that blood, but still preserve the integrity of the blood clot and all of its contents. So we draw this up into the syringe, as you'll see here, and we're going to inject it into this mold. Now, this mold, as you can see there, it's the dome-like mold, is impregnated with kaolin. It's a very strong coagulant, coagulant powder. This is all patented technology. And what we're going to do is we're going to inject this blood into the mold, and we're going to coat that blood with the kaolin that is provided over there. I'm going to skip this part just to that point. Now, this is done at the patient's bedside. You would do your wound preparation as you would normally do, and then you would take the blood, draw it. We're then going to wait approximately 8 to 12 minutes for that blood to coagulate. In patients that are on any anticoagulants, even intravenous anticoagulants, we are still able to draw their blood, and we are still able to coagulate their blood using our technology. So you'd continue your wound prep, and you'd come back later, and what we see here is that you've got this coagulated patch of blood that is going to be attached to the gauze. I'm going to just fast forward in the interest of time. There we have a nice patch of this blood, and we're going to put that clot directly onto the wound bed, and we're going to strap it on and adhere it with secondary dressings and keep it there for 1 week. They'll come back the next week and repeat that. And as I say, depending on the wound size, we're able to heal wounds approximately between 2 and 3 months. We also have a flowable procedure, so wounds that will have a significant cavity. I'm skipping parts of this, but we would do the normal steps of the clot preparation, excepting we don't let it coagulate inside the mold. Rather, we'd inject it into one of these cavity or tunneling wounds, and we would let it coagulate within that space. And that way, we are filling in all the crevices of that blood, which is ideal for resection surgeries and some of these larger wounds that we'll see over here. I'm going to take you through some case studies very briefly, and with that, I'm going to draw to a close. This was a case that we had in South Africa. It was part of our observational pilot, which was published in Wounds International, peer-reviewed and published. This study was led by 5 top academics in South Africa, 5 top key opinion leaders. What we see over here was a 65-year-old male patient that had a diabetic foot ulcer. If we just look here at the general condition of the foot, let alone the wound was covered in eschar tissue. What we see is just the general poor quality of color of the wound, and just the sheer size of it, that we can see his tendons. This patient was scheduled for an amputation. Aside from the complexities with the actual foot in the localized area, he was in very poor health because of this wound. This was his last attempt before an amputation. We used 10 Actigraft applications over a 12-week period. Sister Liesel Nordea in South Africa did this, a key opinion leader here. And we see, I think what's important to note is just look at this. This was week 1, and this is week 4. Look at that difference and the accelerated healing process that we see in these 4 weeks. That's something typical that we see, that in a shorter amount of time, in the shortest period, a lot of the healing is done. In this case, it was approximately 40 to 45% of the wound healing was done in the first 4 weeks. And then going on week after week, from week 4 to week 10, we see that this wound eventually completely closed and healed. The tendons were preserved, everything was preserved, and we see this flesh actually grew back over that area. Again, here, this was a 68-year-old female patient, diabetic foot ulcer. We see, again, look at the general condition of the foot. Look at the size of the wound. This patient was scheduled for an amputation as well. And what we see is, again, this point that I want to point out to you, between the 6th of the 7th, this is July the 6th. We see that from the first week of July to the last week in July, in the first 3 to 4 applications, just look at that amazing progress that we see within that wound. And then week after week until complete wound closure, 8 weeks later, something extremely remarkable. And the results really just speak for themselves. This was a patient, I think limb salvage is an important thing to discuss, especially in the African context. Another diabetic patient, diabetes, something extremely relevant for people on our continent. We look at this patient, what we're looking at over here is the foot. So picture the foot and the toes have been amputated. Often what happens in these cases is we amputate the toes, and if that amputation wound doesn't close, we'd have to do a below knee amputation. So this was a limb salvage case. This was ready to salvage the rest of the leg in this patient. We did 6 Actigraft applications over a 10-week period, and we're able to close up that wound and prevent that patient from having a further amputation. This is a remarkable case from America. Again, in the first case, I showed you exposed tendon. In this case, I'm showing you exposed bone. It was a 67-year-old female patient, didn't want to have her foot removed through amputation, tried Actigraft. They actually used 2 Actigraft applications to cover this area. So week 1, week 2, they kept it on for a bit of an extended period of time, and they were able to close and heal this wound. A venous leg ulcer, I think what I want to draw your attention to, this is the second last case, but just look at the size of the venous leg ulcer. And we saw many venous leg ulcers in our observational pilot that we did here in South Africa. Many of these are in the public sector, and this might be relevant to other emerging markets that are on the call today. But look at the size of this, and Actigraft covers a specific surface area. What we are able to do with the clot, because of the consistency of the clot, we're able to actually cut that clot, and we can fit it to size in a wound. So we don't have to cover the full surface area. We might want to use 2 treatments on one wound like this. Alternatively, we could cut a clot, cover an extended surface area. Again, we don't have to cover that full surface area, but as long as we're covering a majority of it, we are able to start the healing process, and we'll see islands of granulation tissue form, and eventually it gets smaller and smaller. And if you're using 2 kits, you'd see it close until complete contraction and closure. This is another venous leg ulcer that we see here. Just look at the extent and the depth. So both look at the depth and I guess the length and sheer size of this wound, and we're able to close this one as well. This was 10 applications over 16 weeks, and it's just remarkable progress. So I think just to sum up, we've got an extremely revolutionary device. It's something that's simple to use, extremely simple to teach. You can really integrate this within your clinic setting, really in an amazing way. And these are my contact details. I've shared them with you. We are currently importing them into South Africa, and we are looking for distribution around Africa. And we're looking for clinics and clinicians that would be interested in trialing this device and making it accessible to patients that suffer from chronic wounds. With that, I'm going to draw to a close, and I want to thank you all for your attendance.
Thank you very much, Moshi. We appreciate your time and then the excellent explanation you've given. We have 2 minutes for 2 questions, quick ones. If you have any specific question that Moshi can address right now, please unmute yourself. Florence, you can go ahead.
Hello, sir. Please, good morning. Good morning, sir.
Good morning, how are you?
Thank you. Please, I'd like to know the name of the medication used to coagulate the blood sample.
Sure. So the small vial that you see that's provided in the kit is called calcium gluconate. And so it's the blood mixed with the calcium gluconate when it's brought up into the syringe. And then when we inject it into the coagulation mold, it's impregnated with a powder called kaolin, which is a strong coagulant powder.
Okay. Please, how many mils of the calcium gluconate? How many mils?
I'll need to confirm with you. Offhand, I think it's about approximately 5 mils. But again, everything that we need is provided in that kit. So you wouldn't have to go and source that. Everything you need from the blood drawing to the actual coagulation mold is provided for the weekly applications.
Okay, thank you, sir.
Okay, thank you, Florence. I can see 2 more people. I'll do a quick one if your questions will be quick. Patience, go ahead. Hello, patients, you can go ahead. Okay, if patients is not, okay, go ahead. We can hear you so well, patients. You might have to position yourself. Yes, go ahead. We can hear you. Go ahead.
Okay, I want to find out if there are sloughs on the wound. Do you have to remove the sloughs before you apply the Actigraph? Thank you.
So, yeah, thank you for the question. So that's a really great point. What we still need to do with all these wounds is we need to make sure that we're preparing them and preparing the wound bed. So a sharp debridement is often something that has to be done on these wounds. We should remove the slough and we should get that wound as clean as possible. And then we adhere the Actigraft, because that combination is by far the best and the most efficacious, as we say.
Great.
Any
I think
additional
you gave a very good answer. We will do Olayinka last question and then we move on.
Okay.
Olayinka, go ahead.
Yes, thank you, please. Please, I want to, since this process entails the autologous process, I want to ask, can it be used in immunocompromised patients or anemic patients? Will it work?
Yeah, so usually what we say, I think just specifically on that point with anemia is we'd need the clinician to make sure that when they're drawing that blood, that's being done in a cautious way, and it's up to your good clinical judgment to say if this patient would be, if it's good enough to draw blood on this patient, you know, especially factoring in the concerns that we have with anemia. But provided you're doing that and provided that's safe, it will work. It will work effectively. And especially with immunocompromised, you know, so long as we're getting that blood and we're coagulating it, it should work. Again, you just have to use your good clinical practice when it comes to drawing blood with a patient where you suspect or you know that they have anemia.
Okay, thank you.
Pleasure. Thank
Great.
you for your question.
I have someone raise their hand, Juliet. Juliet, can you type your question in the chat box? And then when we have a few minutes, I would put it to Moshi. Thank you very much. We are going to the next presentation, and that is Dr. Maurice Topaz of IVT Medical. Doc, please go ahead.
Hello, thank you very much for this opportunity to present our devices and technology. Let me please share my screen with you. Can you see my screen?
Yes, we can, Doc.
Okay. IVT Medical is a medical device and technology company specializing in research, design, and development of cutting-edge wound healing and closure technologies. Vision is to provide a breakthrough, safe, and effective state-of-the-art, affordable technology to enhance wound wound closure in a global aspect. These are the three devices that we have developed. This is the top closure, the V-Care, and the Me-Care. The main issue actually using these devices is combining them with a technology, with a unique technology that I will briefly evaluate here. The V-Care is actually a unique device that applies vacuum to the wound, but it is a vacuum that is combined with oxygen and insertion of irrigation and antibiotic or antimicrobial agents. Now, another feature which is important with this device is the control on bleeding. The machine would stop and alert when excessive bleeding fills the container. The dressings are off-white, so bleeding can be observed from the outside, and this can be applied for neonates and infants too. Now, the other device that we developed was a substitute for suturing or expansion devices. This is an example of a defect on the scalp that we usually need to fill by flap or skin graft. This is a wound that would usually necessitate a flap or big flap to fill. This is the top closure device where we can apply to the wound edges and slowly stretch the skin to close. Now, these are a few examples that we can see. You see, this is a defect on the scalp of a 95-year-old patient. That for that, you usually use a flap or skin graft. We apply the top closure during surgery, and we can stretch the skin early. And then a few days later, this is 8 days, 10 days, and 2 weeks, the wound is actually closed. So we can stretch the skin in a very simple way and close wounds that we could not close before primarily. This is a wide excision of melanoma on the back. And for this, we usually use a skin graft. This is a procedure that we apply together with the top closure. We can close it within less than an hour. And this is just to show you, this is the conventional way of excising the tumor and applying the skin graft. This is the way that we stretch the skin and close it primarily today. So it actually reduces the chance for flaps and skin graft. You see, this is another defect on the skin. This is the flank, a huge tumor that was resected. And for this, again, this is the conventional way of using flaps to close this kind of wound. And this is using the top closure. This is within 14 minutes. We can stretch the skin and approximate the wound edges. And this is 24 minutes, just completely closing the wound. So this is a totally simple way of stretching the skin and closing the wound in a way that we could not achieve before. Now, this is another tumor on the back of the arm. And for this, you usually need to apply a skin graft or move a flap. You see here, we excise the wound, close it primarily with the top closure in less than an hour, and the wound is actually closed. And this is a later stage follow-up of this kind of resection. This is a huge tumor, recurrent tumor on the shoulder neck area. And for this, you need to apply sophisticated surgery, either free flap or use big flaps. Of course, you cannot apply it everywhere. This is the kind of defect that we got after removing the tumor. And this is just 2 hours, 14 minutes, starting to close the wound. And this is just 23 days after surgery. So this is a substantial change in the way that we approach these kind of wounds, these kind of defects. And here is a 21 months follow-up, as you can see here. We can use it for diabetic foot, and here you can see we use the top closure together with the V-Care, using oxygen, irrigation, and vacuum, mobilizing the tissue by the top closure and approximating the wound. And here you can see the closed wound in a well-managed way. This is again a diabetic foot, and for this, you can apply all kinds of medications, but we need to close the wound, and we close it very fast, 45 minutes of surgical procedure, and the wound is closed. Of course, we cover it with the raw NPT, oxygen, irrigation, and vacuum, and then within 2 weeks, the wound is actually closed. So the process, the whole process is very short, and we can use the soft tissue without any scar tissue that would otherwise build within the wound edges. We can use it for pediatric application. You see, this is the congenital nevus in a 3-month-old baby. We apply the top closure just by sticking into the skin, gluing into the skin, stretching the skin, and closing the wound in stages. And before 2 years old, we actually can excise the whole wound and get the defect closed in a simple and early stage. We can apply it for combat injuries. This is an Israeli soldier that was injured actually 2 days before, and this is Thursday. Now we took him to the operating room, and this is the same day, 44 minutes, and the wound is closed. Now we get the best closure, stretching of the skin, and immediate closure of the wound. And you can see this is 6 weeks follow-up. And this is the kind, and you see again, you can hardly see a scar. And this is the kind of activity that he was engaged following this injury. Now, this is a case of necrotizing fasciitis. And this is the way that we close these wounds. We apply oxygen, irrigation, and vacuum. There's, of course, a whole vacuum system. The VK is applied on top of it. And the wound edges are stretched in a very fast way to close the wound. And this is 24 days following the initial closure of the wound. So we can close these heavily infected wounds very early. And this is just 52 days after the surgical procedure. This is again, you see, this is a case of, again, necrotizing fasciitis. And this is just 5 days following the surgery of closure. And this is just 3 months later. So we can cut the whole healing process into a very short process, skipping the long-term period of wound healing by wound stretching. This is another case of necrotizing fasciitis, and you have it all over the world. And you need to manage this issue. And here you see 18 days following the initial closure. And of course, we use it together with the top closure, the vacuum, oxygen, and irrigation. And this is just a later stage complete closure of the wound. Again, necrotizing fasciitis. And again, you have to treat these wounds aggressively in order to close them primarily. So we are not talking about wound healing. We're talking about wound closure. And this is what we get. We need to get the closure as early as possible. So it is still a sophisticated procedure. We apply the oxygen, irrigation, antibiotics into the wound and close the wound as early as possible. And this is the healed wound. You see, we don't use any flaps. We don't use any skin graft, but we close the wound primarily. Now we can close an open abdomen. And of course, you have it all over the world. This is a major issue in surgery. And this is closed primarily. In one stage, we close the whole wound using the top closure, the raw NPT, oxygen, irrigation, and vacuum. And this is the end result. You see, this is a huge tumor in the abdominal wall. And this is the tumor that was resected. Now just think about the time that it would take to close this kind of wound, or the kind of flaps that you need to apply. And of course, you cannot do it everywhere. Here we apply the top closure and the vacuum system. And again, it would take about 5 days to close the wound completely, but this is just 18 days later. The patient can walk around with the wound closed. This is a baby following a liver transplant that could not be closed. But here we close the abdomen. Of course, this is there's a lot of technical issue to explain, but this is just 8 days later. And this is the long-term result. We didn't have to use any flaps. We don't use any flaps. We don't need to use any skin graft. We close the wound primarily. And this is a newborn with a huge liver. This is a tumor that developed and that actually was combined with acute abdominal pressure, and we could manage the whole wound together with the raw NPT with the top closure to close the wound completely after 33 days after surgery. Again, this compartment syndrome required the opening of the gap of the abdominal wall, and again, being able to close it in a very short time and having the abdominal wall closed completely. This is the case that we did in, one of the cases that we did in Kenya, using the top closure, the VK with oxygen and irrigation, closing the wound. This is, I'm just scrolling through so many applications of this system that are currently actually changing the standard of care of wound closure. I'm not talking about wound healing. I'm talking about wound closure. And this is a pressure ulcer that you all know how long it would take you to close. But here you see we excise all the scar tissue, the dead tissue, and we close it primarily during the surgery, at the end of surgery. And this is just 7 weeks later, the wound is actually closed, completely closed. And this is another case, one of the cases that we did in Kenya. So you actually can do it in any kind of operating room. You don't need any sophisticated technology or facilities to close these kind of wounds. And we do it for infected sternal wounds. We close them primarily during surgery. We resect the dead bone, we resect the osteomyelitis, and we close the wound primarily. And we can use it for veterinary use. We use it on turtles, eagles, and so these are the products that we have. And let me just get back to you. And that would be the end of my talk. Thank you.
We appreciate your very, very nice pictures. We would like any questions. I could see Olainka's hand raised. Olainka, if you have a question, please go ahead. Okay, if no question from there, anyone else has a question? Doc is willing to take some questions. Okay, I have a hand raised. Please go ahead.
Okay, thank you, please. I want to ask, thank you for the presentation, Dr. But I want to ask, since the top closure from all the wounds that has been shown to us, well, I realize that it's not in every wound that it closes with first intention. So since there is an opening, is it possible? Have you recorded complication of risk for infection, please? Have you recorded any?
When we use when using the top closure in infected wounds, we use them always use them combined with the raw NPT. This is a whole system that works together. You cannot close an infected wounds primarily. You have to use the VK and the oxygen, irrigation, and vacuum. So when closing the sternal wounds, for example, we close them primarily, but then we combine with application of antibiotics to the wound, oxygen, and vacuum. So the top closure is meant for stretching the tissue, stretching and approximating the wound edges early, but you have to combine it together with the vacuum system. Again, this is not a conventional vacuum system because the conventional vacuum system would grow anaerobic bacteria inside the wound. You have to apply together with the oxygen and the irrigation that we use, mainly antibiotic solutions.
Okay, thank you. But please, I need more clarification. I meant if you use it and the wound did not close 100%, don't you think it can prone patients to infection? And I'm asking, have you recorded that as a complication in any of these wounds?
No, listen, this is not a cause for closing these kind of wounds. You know, I usually, I'm a medical doctor, and I can give a course for a day or two just to instruct you exactly how to close the wound. What I just presented were just sample cases that we did it in heavily infected wounds. For example, necrotizing fasciitis is the most heavily infected wound. And this is what we do. This is the current procedure that we do for necrotizing fasciitis. So of course, we don't close it on the first day, but we close it very early when combining the oxygen, irrigation, and antibiotics, and stretching the skin to close it. So, but again, you don't combine it. You don't need to combine movement of flaps or putting a skin graft that you can actually lose. So this is much safer than moving a flap. This is much safer than putting skin graft because you don't burn any bridge this way.
Okay, Doc, I think the last part of a question you can touch on, which is what is the percentage of infection you get, let's say for 100 of such cases that you deal with? Do you get any infection happening after, or this is a foolproof way of dealing with such wounds?
Well, again, you don't close the wound completely until the wound is actually clean. So if the wound is still infected, I would not close it. I can approximate the wound edges. I don't let them retract away. So of course you would not close the wound. That would be a mistake to close an infected wound completely. But we can close it, as you saw with the open abdomen, with you saw of the sternal wounds. We close them completely when this is controlled, when we can apply the antibiotics to a specific, an infection that is sensitive to the antibiotics. And the chance for reinfection is there, but it would be relatively low. I use it for infected pacemakers. And we have about 85% of success in infected pacemakers. We have published this. This is, you can read it in Circulation. But this is something that we can discuss later. This is not it wasn't intended to, it's not a course for using this technology. I'm just stressing that this is the current application, the current technology that we use for treating these kind of wounds, heavily infected wounds.
Okay, Doc, thank you very much. I must say we've been in touch with Dr. Topaz for almost 3 years, Doc, right? And we've been looking for opportunities for him to come and do like a practical session in Ghana. So we would love to hear your comments. If you have anything that you're interested in, that you'd like to engage Dr. Topaz on, we are very much happy to do this. We would move on to the next and a very, very interesting, yet kind of different solution. And this is Medco Technologies. Amir, you can take it away.
Thank you. It's actually Dr. Gadi Boko who is presenting. Thank you. So hello, good morning to everyone. Thank you for inviting me to give this talk, and let me share my screen. You need to stop the screen of Dr. Topaz. Okay, now I can continue. Okay. Okay. Can you see my screen now? I assume you can see my screen? Yes. Okay, good. So I will be talking about wound dressings in which the active ingredient is copper. Obviously, copper, everybody knows it's a mineral in the earth, but not too many people know that actually copper is an essential mineral that we need in order to survive, because it's involved in almost all our tissues in our body. It's an essential mineral. We need to consume approximately 1 milligram of copper a day. Now, another important thing is that copper has a very wide spectrum biocidal activity. This is a partial list from A to E of different bacteria that are killed, and this is a relevant reference showing that they are killed by copper. The same goes for fungi and for viruses. And the main message here is that copper is a very wide spectrum biocide, and obviously this is a very important attribute when we're talking about wound healing. Another important thing to understand is the biocidal mechanism by which copper kills bacteria and other microorganisms. And the first damage that the copper does is to the envelope of the cell wall of the bacteria. It damages, and by damaging the lipid by peroxidation, it allows copper ions to penetrate into the bacteria and do non-specific damage to the genetic material, RNA and DNA, and also to disrupt the respiratory energy production and interact with other proteins and not allow them to function. So the main message here is that we're talking about a multi-site, non-specific kill mechanism. And obviously, this makes it very difficult for bacteria to develop resistance or tolerance when they're exposed to copper. And obviously, once again, this is a very important attribute when we're talking about medical devices, and obviously when we're talking about wound healing as well. What we develop in our company is a way to impregnate cuprous oxide microparticles. And the reason we're talking about cuprous oxide is because cuprous oxide is a very active, non-soluble, is the most active biocidal form of copper. This patented technology allows us to impregnate the cuprous oxide into different polymeric materials and make fabrics or other plastic devices, etc. What you see here is the wound dressings, which is made of 2 layers. The external layer, the orange layer, is the layer that comes in contact with the wound bed. It's, as you can see here in this scanning electronic microscopy image, you can see the white dots. Those are the cuprous oxide microparticles which are embedded in the fabric. These fabrics is a non-adherent fabrics, and it allows the exudates of the wound to cross through it into the second layer of the wound dressing, which is a highly absorbent layer that has also cuprous oxide microparticles. And we have wound dressings with an adhesive contour or without an adhesive contour that can be cut to the shape of the wound. Now, by impregnating the wounds dressings with the cuprous oxide microparticles, we endow them with very potent biocidal properties because of the copper. And this is an example of an assay which is well accepted in the industry, in which you inoculate, in this case, controlled dressing or our dressings with 1 million Staphylococcus aureus bacteria. In the controlled dressing, because it's at 37 degrees with humidity, you can actually see the bacteria proliferating. But when you're talking about our wound dressing, you can see that within 60 minutes, there was a 4-log reduction reaching the lower limit of detection. So basically, the bacteria cannot survive on the wound dressing. Today, most of the antimicrobial wound dressing in the market have silver in them, approximately 70% of the market. And when we compare ourselves, in this case against MRSA, 1 hour of incubation in a similar assay, you can see that some of the commercial dressing, at least within 1 hour, they did not have a good antimicrobial efficacy. Some of the silver dressing did show good antimicrobial efficacy. And once again, what I can tell you from this slide is that we demonstrated a similar, if not better, efficacy than most of the commercial silver wound dressings in the market. And based on this antimicrobial efficacy showing above 4-log reduction against gram-negative and gram-positive, including antibiotic-resistant bacteria, when the dressing is completely full with wood exudate, even after 7 days of use, we obtain the FDA clearance, CE and additional clearance, also based on passing all the biocompatibility tests which are needed in order to receive clearance by these regulatory bodies. And today, we have the FDA, the CE, other regulatory approvals, and we are mass producing these wound dressings in order to treat acute and chronic wounds for the last 2 years. Now, up to now, I have been talking about the antimicrobial properties of the wound dressings, but let me show you a few cases before I get into other important properties of the copper, very relevant to the wound healing aspect of closing a wound. So this is a patient, 62 years old, with a varicosis arterial hypertension from Austria. And here, this is when they started using our wound dressing. As you can see, there is a biofilm, clear biofilm, but after 10 days of use, the biofilm is gone. And once again, notice the granulation tissue being formed, because I will discuss this in more detail later. This is another case from 23 years old individual with renal failure, necrotizing fasciitis of the forearm, treated actually, I think, in Kenya. And once again, I arrived to the clinic and was treated for 2 weeks in this case. And after 3 weeks, you can see the wound is clear, very nice granulation tissue, and he was ready for skin grafting. So I show you many other cases of that, but I think one of the important things I want to discuss is the wound healing properties of copper and how they come into, how can they improve the wound healing when the copper is in our wound dressings. So we already in 2008 published articles in which we hypothesized that chronic wounds cannot heal because the copper level in the wound itself is very low. And we arrived to this conclusion based on many, many reasons, which I will not discuss now. But what I want to show you now is a few cases of not infected wounds in which using our wound dressing has a very significant impact. So this patient in 2013 was 34 years with diabetes, neuropathy, and she had a transmetatarsal amputation of the foot, but for 6 years, they were not able to close the wound. She arrived to the clinic in 2019, started to be treated with our wound dressing in June. And as you can see here, after this is 1 week later, you can see a reduction in the wound volume approximately of 90%. And after 6 weeks of treatment, the wound was completely closed. Once again, for 6 years, they were not able to close the wound, and this is not an infected wound. Another case, this is again from Africa, a female with sickle cell disease. She was treated with different dressings, including silver dressings, arrived to the clinic with multi-drug resistant E. coli. She was, after debridement and treatment with our wound dressing, you can see after 7 days, the wound looks clean, very good granulation tissue, and once again, she was sent for skin grafting. This case in Israel is a 70 years old female with diabetes. She arrived with very significant necrotizing wound. After very deep debridement all the way to the bone, they were about to amputate the foot, but decided let's try to salvage it. It's important to understand that they also had to remove the main artery that goes through this foot. As you can see here, no significant improvement occurred after using regular wound dressings. Here, they started to use our wound dressing, and already after 5 days, you can see a significant improvement. Let me show a larger image. You can see here the bone actually was covered, which is not a very easy thing to do. And this is despite not having the main artery going through the foot. So once again, we salvage the foot from amputation. Another case of PVD, peripheral vascular disease with amputation. As you can see, this is once again from Africa, a very significant case with in which 12 days later, you can see very significant improvements of the wound. After 18 days, once again, please notice the granulation tissue, which enables the skin grafting to occur. Another case from Israel, which I think is very interesting, a lupus, an individual suffering from lupus. She arrived to the clinic with this small wound, and the wound continued to increase in size, even though they tried debridement, they tried negative pressure wound therapy, first skin graft, 3 weeks of a pressure chamber, second skin graft, other treatments with other different types of wound dressings. And for almost 7 months, they were not able to close the wound just increased in size. And here they started to use our wound dressing, the copper oxide dressings. And I want to show you in an enlargement how, when they started to use our wound dressing, and this is after 3 months, you can see the wound is almost closed. There's still a small area which is not closed, but you can see the epithelialization. And once again, this is after 8 months or 7 months that they were not able to really improve the wound. And another aspect of using our wound dressing is post-op related usage. You can see here that this is after 20 days of using our wound dressing. You can see usually after post-op, there's a very significant inflammation. You can see here the wrinkles. And once again, this is another thing that we have noticed using our wound dressing post-op. You can see a very significant reduction of the inflammation, which allows a much faster improvement and closure of the wound. Another thing that we notice using our wound dressings is a reduction of the scar. You can see here at 2 weeks post-op using our wound dressing in our orthopedic intervention. And this is 7 weeks later. You can see really a reduction, a very significant reduction of almost 80%, I would say, of the scar, which is almost invisible. Now, I have been, and this is a clinical trial that we have conducted in one of the hospitals in Israel, in which diabetic patients that during the screening period did not show any significant improvement of their wound, they were started to be treated with our wound dressings. And you can see here the mean size normalized to the initial size of the wound. And as the treatment with our wound dressing starts, even after 1 week, already there was a statistically significant reduction in the wound size. And people, individuals without plantar wounds, the reductions were even more dramatic. And those with pressure, there was a reduction, but which did not reach a statistical significant level. So all these non-infected wounds treated with our wound dressings, the effect cannot be explained by the antimicrobial properties of copper. Something else is happening here. So we actually conducted some studies, in this case with diabetic mice. In these mice, once again, this is a non-infected wound. It takes approximately 1 more week to close in these diabetic mice as opposed to normal mice of the same strand. And what you can see here, we treated 2 groups of mice. One group was treated with control pads without any active ingredient. The other group was treated with the copper oxide impregnated dressings. You can see that already after 10 days, there was a statistically significant reduction in the wound size. And in terms of kinetics of the wound closure is like if we make the closure as a normal rate of closure, despite the mice being diabetic. When we repeated this experiment, but in this case, we added another group of mice that was treated with silver dressings, and we also increased the number of mice in the group. As you can see here, there was no difference between the control treated mice and the silver containing pads treated mice. But once again, the copper treated mice already after 6 days, in this case, there was a statistically significant reduction in the size of the wounds. So we were able to demonstrate enhanced wound healing in this diabetic model of mice. By taking a biopsy we analyzed the tissues by histology first. And as you can see here in the copper-treated mice, not only there is normal histology, but there is earlier appearance of glands, hair follicles, normal epidermal layer, etc. We also analyzed the expression of more than 84 genes and analyzed the ratio of their expression compared between the mice treated with our wound dressings versus the control group. And as you can see here in this particular genes, at the beginning, there is no difference, but as the wound healing progresses, there is a significant increase of some of these genes. Many of these genes are related to angiogenesis and extracellular matrix protein expression. So we then analyzed the immunohistochemistry, and we use this factor that stains blood capillaries. You can see here a very significant increase in the copper-treated mice of the staining of the blood capillaries. Once again, I'm reminding you of the granulation tissue, which we have experienced in many clinical cases. Other factors like vascular endothelial growth factor went up, and also epoxy-induced factor 1. And we published this already in 2010. So one of the important things that we believe is happening with this, with our wound dressing, is that because of the different redox between cupric and cuprous oxide, the different oxygenating levels of the copper, there is epoxy in the wound, which is very important in the initial steps of the wound healing. This causes IF1 alpha to go up, which upregulates many cytokines, which induce angiogenesis. There is also extracellular matrix synthesis, induction, epithelialization, immune cell recruitment, endothelial cell proliferation and migration, intense metabolism, and we realized already in 2010 that this is a critical factor. Those people who received the Nobel Prize in 2019 for medicine, they are the ones who discover IF1 alpha and its role in sensing the oxygen level, the intercellular level of oxygen. So it's nice that we realize also that it plays a very important factor in the molecular mechanisms of enhanced wound healing by our wound dressings. Another important thing that we notice is that when we expose human dermal fibroblasts to increasing concentration of copper, there is a increased secretion, production and secretion of collagen, elastin, fibronectin, which are very important extracellular matrix proteins that form part of the strength and elasticity of the dermal layer, and other factors like TGF-beta, and once again, vascular endothelial growth factor. This study, not published by us, actually done with healthy normal mice. In these wounds, when they applied PBS, which is buffer phosphate saline, it took 70 days to close the wounds. But when they added copper into the solution, it took only 11 days to close the wound. And when they added a chelator, something that takes away the copper from the wound, it took 21 days. So once again, confirming our previous observations. And I will not get into, this study actually was done in rats, in which they measured the amount of copper in the wound immediately after wounding. And as you can see here, normal rats, there is almost a 40% increase in the amount of copper secreted into the wound. Once again, showing that it's a physiological way of the wounds to deal with the wound by secreting copper into the wound. Now, this study actually shows they measure in diabetic patients in the sera the amount of copper in the sera, and they found that in diabetic patients without foot ulcers, actually they had higher levels of copper in the sera. So I think more and more the scientific community is realizing that copper ions play a very important role in wound healing. So what we believe is happening with our wound dressings is that they serve like a slow release mechanism which constantly release at ppm level copper ions. These copper ions in the wound, they induce, first of all, angiogenesis, which is critical. You need good blood supply to the wound to facilitate not only oxygen and removal of CO2, etc., but for all the cytokines, etc., needed in order to produce new blood capillaries to arrive, etc. They also, the copper released from our wound dressing stimulate the production of collagen and other extracellular matrix proteins by the dermal fibroblast. And all these, and as we have seen right now in some of the cases, the copper is involved all the way throughout the wound healing, including all the way to the scar formation and improve the scar formation. And the most important thing, the enhanced wound healing. So in addition to conferring protection to the wound and clearing wound infection, they actually stimulate wound healing. So I will be happy to address any additional questions that you may have, and ready to answer any questions, and I hope I did it on time. Hello?
Hello.
Yes.
Hi, Doc. Thank you very much. We appreciate your excellent delivery of this solution. We will take questions now. If anyone has a question, we would be interested to hear you. Okay, Mr. Choi, you have the floor. Please go ahead.
Thanks, Doc, for the presentation. My simple question is the toxicity of the minerals. We know very much that inorganic minerals, such as copper, may have some form of toxic that might not be the best. How do you handle that aspect?
Okay, thank you for the question. So obviously, currently, we are the only company, as far as we know, that has regulatory approvals to use copper in wound dressings. And the main reason is we developed a technology that, on the one hand, does not allow the release of, first of all, of copper particles. We're using microparticles, not nanotechnology, but microtechnology. And there is no release of copper particles into the blood system. We had to demonstrate this to the FDA initially, and then to the other regulatory bodies. The amount of copper that is eluted is, as I said, in the ppm levels, it's much below any toxic level. It's important to understand that copper is extremely well metabolized by our body, but still we had to conduct acute toxicity, chronic toxicity, skin sensitization, skin irritation, and we passed successfully all these tests. Our wound dressings are already being in use for almost 2 years now. I think hundreds, if not thousands of patients already, and we haven't had any adverse effect so far. There are some reports in the literature about copper allergy. Now, this is mainly to, earrings or bracelets, but there is a discussion in the literature, is it really allergy to copper because copper is an essential mineral, or is it more because in these earrings, etc., there are impurities which may have caused the allergic reaction. So, so far, this is considered a very safe product. It's allowed for use in chronic and acute wounds up to 7 days, or until the wound dressing is completely full with wound exudate. And we haven't had any toxicity issues. And it's important to understand that this technology has been used. We have been working with this technology for more than 15 years in many, many consumer products as well. This is being used in hospital to reduce nosocomial infections, etc. It's widely used without any issues of toxicity whatsoever.
Okay, great. I hope, Mr. Choi, your question is answered. We will take a second question from Ruby. Ruby, you have the floor. Please ask your question.
Okay, thank you for the wonderful presentation. My question is actually in relation to the first person's question. I wanted to ask that there's no situation or in any case, the copper oxide dressing will be used for a long period of time. So the person will not be exposed to any side effects or anything like that. That's what I wanted to ask.
Yes, thank you for the question. Right now, as I said, our wound dressings are being used immediately, let's say in infected wounds, but also post-op in non-infected wounds. And in infected wounds, after cleaning the wound from the infection, they continue to be used all the way until the wound is closed. So this can actually, I didn't show you many of the cases because of the time constraints, but we have cases in which the wound dressing were used, let's say, for 4 months, until the wound was closed, even for, so it's being used for, so it's important to understand that the wound dressings are appropriate for all stages of wound healing, from infected wound immediately post-op on, or all the way from chronic wounds until they're really closed. And so they're being used for very prolonged periods of time without any issue.
Okay, we have space to take one more question and then we move on to the next presentation. Anyone with a question, please unmute yourself and go ahead. Okay, so I think it that we don't have a question coming in. I would like to acknowledge the presence of Charmaine Hitchowitz. I hope I got your name right. It's a pleasure to have you here. She is the trade officer for healthcare at the Israeli Trade and Economic Mission in South Africa. She's an experienced trade person, and we appreciate your presence here. Thank you very much. All right. So we do the last presentation, and this is from Eyal Nuri of Ensis Surge. Please go ahead, Eyal.
Hi, good morning, everyone.
Good morning, Eyal. Hello, Eyal. We can hear you, so you can go ahead. Okay.
Yes, hold on.
All right.
Okay. Okay, can you see my screen?
No, we also don't have you on video. We can't see your screen, and we don't have you on video too.
Okay, just a second. Let me figure it out. Because the recent, okay, let me start video. Okay. Hi, guys. The recent application of Zoom changed the audio concept, so I cannot present from my computer. So I'll try to share my screen and show you from here. Start now. Okay.
While Eyal is trying to get his presentation on, if you have any questions, please put them in the chat area and I would ask them for you. I would like to try and put across this question to Moshi. Moshi, there was a question from Atar Boating, who is asking, is the Actigraft reapplied for the preceding weeks, or a new Actigraft is made for every other week? Moshi? Okay, I think Moshi also dropped off. He might have had another engagement, but I would get this question answered for you, Atta Wataman. Yes, we can see your screen now, Ayal. Hi, Ayal. Hello, Ayal. Hello, Ayal. Yes, we could see your screen, but the presentation has gone off. Hello, Ayal. Okay, I would like to remind everyone that the opportunity to do a private meeting with any of these companies is still open. Immediately after Ayal is done with his presentation, we would open up some meeting rooms which you can join to have a private session with any of the companies. So kindly fill the form that I have put in the chat session, and we would try and book the meeting for you. Thank you. Hello, Ayal.
Can you hear me?
Yes, we can hear you, but your presentation is not up. But for the sake of time, you can begin, and then we
What
can work out.
what I do, I'll try to, because there's a problem with my computer with the voice.
Okay.
I'll do it from, I'll talk from the phone and I'll show from my PC.
Please go ahead. Yes,
okay.
Yes, we're happy with that.
Okay, I'm waiting to join the meeting.
Okay.
Okay. Let me try share my screen. Okay, connecting. Sorry for that.
Okay. We apologize for the little technical hitch.
Do you need to approve it again? Because it's waiting for approval.
On my end, you are joining. I think it would be a connection problem.
Okay.
I think you're connected now.
Okay. It's coming up.
Okay, great. We thank you for your patience.
Okay, perfect. Do you see? Okay, I'm sharing it. Can you see?
No, we haven't seen your screen yet, Eyal.
Okay. I think we managed to bypass all the technical issues, guys. Thank you for, and sorry for waiting.
It's our pleasure. Please go ahead, Eyal.
Okay, so I'm very glad to introduce our solution, Silverstream. Silverstream is a wound management that comes in two formations, one of a solution and one of a gel. It's coming, the main advantages of the solution and the gel are, we are doing all three stages of wound management. We are doing, first of all, the debridement, removing all the necrotic cells. We are doing the disinfection stage. And then we are also doing the healing process, which is generating the granulation tissue, reinfection, removing and all kinds of biofilms, and later on generating new tissue and without scar. The first one that introduced to the market was the solution. The solution contains main thing is the silver ions that treating the biofilm and stopping the replication of the bacteria, and then other material are doing the healing. The product is approved in a couple of countries already, and Ghana is one of them. We have a regulation approval for using the product in Ghana. The gel is a new product that was introduced this year. We already approved it in USA and received a FDA certification for the product. The gel is coming to close the wound, where the solution is going inside the wound. And together they are providing a higher synergy and complementary solution working together. So the process of how you are treating the wound is, first you use the solution and cover the wound completely and fight all the initial infection and biofilm. Then you use the gel as a dressing coming on top of the wound and close it. And later on, you can use other bandages or things like that to make sure, but depending on the wound. If the wound is early stages, you use bandages. If it's latest stages, no need for bandage. How does it work? The silver ions has 3 mechanisms of action. First of all, we damage the cell membrane by reacting with the proteins. So this causing condensed DNA to stopping the DNA replication of the bacteria, and we interfere with the respiration process. Once we do that, then there is no replication of bacteria, and then the other ingredients of the silver stream comes into action and working on the healing process. When you look about the safety of the product, first of all, there is no irritation. People that use that experience a very good feeling. They don't have the feeling that they want to scratch their wounds. There is acute systematic toxicity. The product is not toxic. And the things that when you cover the product, you use the silver stream and then you cover it with bandages, you can open it after a day or even 2 days, and there is no bad odor because of the menthol ingredients of the product. So it lets the product working between bandage to bandage, and it's working perfectly. When you look about the silver stream, it has a couple of ingredients that give us a broad range of covering the whole stages of the wound management. There is broad antimicrobial activity that destroying all kinds of bacteria and viruses. It destroyed the biofilm using the silver ions with the 2020 and menthol. There is no bacterial resistance, so there is no infection of the wound. It reduced the pain using the menthol and glycerol ingredients. It's, as I mentioned, it's eliminate the odor of the smell because of the menthol. It's prevent maceration. It's promote the wound and burn healing. So we're talking about a real short period of wound healing. Here's an example that the treatment between silver string versus saline when you want to clean and disinfect the wound. You can see that in the left side, the number of bacteria reduction after 55 minutes, this is a log CFU. There is a huge degradation compared to the saline on the left, on the right side, where after 355 minutes, it still didn't do anything. So when you use the product, the silver stream, it's better using for both disinfection and also for the healing. Some of the pictures here demonstrate that using the silver stream, wounds that fail to heal are healing very quickly using the silver stream. These kinds of ulcers or patients with chronic ulcers, once they use the silver stream, after a few days, you see a great result. Here you can see that with pressure wounds, after day 1 and after day 3, you see how the wounds start to cover and how the wounds start to heal. And this is different type of wounds. Here are some examples from case studies we did in India. You can see the product after using it after 20 days before and after it looked after debridement. You see how the wounds are clean and ready for healing. And then the healing process after 20 days is almost done. The product has been used for more than 10 years. We have over 150,000 patients treated successfully worldwide. We show a complete safe profile using this treatment and not even a single adverse event that we had. We managed to show that we shortened the treatment time by 30 to 50%, depending on the wound and depending on the, of course, number of silver stream use. Guys, thank you very much. Do you have any questions for me?
We appreciate it, Eyal. Thank you very much. Any questions for Eyal? If you have a question, please, you can unmute yourself and ask the question. Hello? Hello, Grace, you can go ahead. Hello, Grace, we can hear you very well.
Okay, let me come. My name is Kodo Choi. Yes. May we then assume that this wound healing agent is meant for not a big open wound, but for a smaller wound? Because the gel that, let's say, foot ulcer or open wound will take is going to be a huge volume of the gel. So is this something that you focus on the minimal sized wound, or how do you handle much bigger wound that can take up a whole, maybe 3 bottles of your 100 ml gel?
When you have a bigger wounds, you should use the silver stream, and then you take you soak after you clean and disinfect the wound, you are taking a bandage and you soak it with the silver stream, and then you cover it for a few hours. You can do 2 treatments per day, and then you can move to 1 treatment per day. Make sure that the bandage is soaked with the silver stream to cover the whole wounds. When the wounds become small, when we call it talking about minor wounds, you can just cover it with a gel and then cover it with a bandage or not. This is depending on the wound size.
So the silver, your product doesn't have the antibacterial effect. It only promotes because I saw you saying that the silver actually damages the bacterial cell membrane and others. So it has some antibiotic property, but you mentioned that we should do the antibacterial process before applying the gel.
The main difference between the gel and the solution, the properties are the same. Both of them are antibacterial products. The main difference is that the solution, since it's a liquid, it can go into places in the wound that the gel is not able to reach. So you use it both. You use the solution first, and then you put the gel on top.
Okay, understood. Thanks.
Okay, thank you.
Okay, Grace, it appeared, Grace Sappho, it appeared you wanted to ask a question. If you do, kindly unmute yourself and ask. While we're waiting for any more questions, to Silverstream or any of the other companies, Medco, IVT Medical, and then Silverstream, I would like to remind you that there's still an opportunity to meet any of these companies immediately after the session is done. You just have to fill the form on the chat box, and then I can make the connections. Any more questions, please? Okay. I think that would be a wrap then. Thank you, Eyal.
Thank you very much.
Yes, we
Thank
know
you.
it was on short notice and you did your best for us. We appreciate it. Thank you, Dr. Topaz. It's been amazing. We enjoyed your pictures. We enjoyed your technology and what it had to share. Thank you, Dr. Gadi and Amir. You guys have been strong for us, and we know that we will do our best in the local space for you. I would ask Charmaine if you have any comments, anything to say regarding South Africa. I know there are a few South Africans on the Zoom, so Charmaine, if you have any words to share, any last comments, please.
You're also welcome to contact me direct if you want to meet with any of the companies that presented, and I'll gladly make the introductions.
Okay.
Thank you. Thank you. It was a very excellent presentation. Excellent webinar. Some gory pictures, but nonetheless, excellent.
Yes, we agree.
Okay.
I would like to ask Eyal. Eyal, I have a question for you. You said your product is registered in Ghana. Who are your local representatives in Ghana, please?
Hi, we are working with a company called Eton Glue, who are representing us in Ghana. And we have the product has been registered and ready to be used.
Okay, we would like you to share the local contacts details with me. And then when I'm forwarding the video recording, I will share with everyone so that they can contact them.
Sure.
Thank you very much, everyone. It's been nice and sweet. We've had a very good representation, and we hope that you find a significant solution for your hospital or your practice or some patient or some family member that you know. My contact is in the email. If you want to contact me for anything, kindly do so, and we'll gladly have you on another session again soon. Enjoy your day and your week. Thank you.
Thank you. Bye, everyone.
Cheers.
Thank you. Bye.
Bye.
Thank you. Bye-bye.
Thank you. Thank you very much.
Thank you. Bye.
Thank you. Bye-bye.